Okay, thanks everybody for tuning in. This is the Neurotology Eastern Region Virtual Education Series, meant for fellows, but also for residents, medical students, and to drive communication within our community. Lectures are live and will also be posted on the Nerve YouTube channel for later viewing. Today, we have leading a discussion, Dr. Habib Rizk. He completed residency in Lebanon and then also fellowship under Michael Teshido and a fellowship again at MUSC. He is our vestibular guru and so fortunate to be able to have him lead a session on vestibular cases today. Hopefully this will generate discussion, so feel free to chime in, ask questions, and we'll go from there. Thanks, Dr. Rizk.
Thank you, Mallory. I'm going to go ahead and share my screen and get started. There's a lot of cases, but we probably won't be able to cover everything in one single session, but we'll try to do hit one of the most important and interesting ones at least. Is it sharing or not yet?
Almost.
Are you seeing my screen?
Yep.
Okay, perfect. Hopefully the animations will work in that format. I've never done it when we share it like this. So basically, the educational goal of that lecture is to understand site of lesion, pathophysiological mechanism of vestibular disorders, and know how to evaluate and manage a patient presenting with this. Whether you're a neuro-otologist, otologist, or general otolaryngologist, you'll be called on to evaluate the patient with dizziness, unless you put a specific block not to see those patients. So it's always, I tell residents, always at least get a working knowledge of this, because you can help patients sometimes that have been dismissed, discover certain diagnoses. At the end of the day, we are the experts of the ear, and we know the peripheral vestibular system better than anybody. This slide summarizes everything you need to know about the anatomy of the peripheral vestibular system. We all know there's a vestibular nerve that is divided into two branches, the superior and inferior branch. The superior branch goes to the superior canal, lateral canal, and the utricle, and the inferior branch goes to the posterior canal, ampulla, and the saccule. Of course, there's some anastomoses, but this is basically the best the most general representation of what the innervation is like. And interestingly, the vascularization of the vestibular system also follows the same pathway. You have the labyrinthine artery that gives the anterior vestibular artery that follows the superior vestibular nerve. And then you have the common cochlear artery that divides into the posterior vestibular artery that follows the inferior vestibular nerve, and the cochlear artery proper that goes into the modiolus. In order to understand what the vestibular system, how the vestibular system works, we also have to remember that it's always working, even when we are at rest and not moving, and both vestibular systems are firing simultaneously, kind of like the two motors of a plane. Or so when one rudder is pulling more than the other, the plane is going to move to one side. And so on and so forth. And actually, the nomenclature of the eye movements follows the nomenclature of the movement of the plane in aviation. Yaw, pitch, and roll are the names we give for the planes when they move during those along those 3D planes. When a patient comes to be evaluated for dizziness, your most important job basically is to get enough of a history to define or categorize the symptom into those four broad categories. A vertigo is an illusion of movement of oneself or the environment, typically as a rotation, but the broad definition of vertigo is any illusion of movement. So a rocking sensation is, at the end of the day, a vertigo. So patients who present with the Mulder-Barkman syndrome describe a rocking sensation. That's a type of vertigo, but the rocking sensation is typically not coming from the ear. Lightheadedness or presyncope, although it's usually hemodynamic, bear in mind that any vertigo can cause a vagal reaction that leads to lightheadedness. This equilibrium can be due to a peripheral or a central vestibular system. And oscillopsia Oscillopsia is one of the most difficult symptoms to elicit from the patient. It's the subjective illusion of visual motion. And basically, you can ask the patient, are things moving when you move, and only when your eyes are open. So the vertigo, the illusion persists even when their eyes are closed. Oscillopsia, by definition, you have to have your eyes open and you have to be looking at something to have the sensation of oscillopsia. And that's what oscillopsia feels like. And the hallmark condition that causes this is bilateral vestibular hypofunction. The first thing you do when you are examining a patient with dizziness is check for nystagmus. When it's evident, you will see it even without the Frenzel lenses. Of course, if you have the opportunity to get the infrared goggles in clinic, and they are available at not a very expensive rate, you can see it without visual fixation, and that can put in evidence milder forms of nystagmus. What I also stress in the clinical exam with the residents is that you have to know how to describe the nystagmus. It's not sufficient to say patient has nystagmus. You have to know what the amplitude is, and the amplitude is typically graded between 1 and 3. For example, if you have a right vestibular neuronitis with a left beating nystagmus, is that nystagmus beating in all directions of gaze to the same side? Then that's a grade 3. If the nystagmus is only beating to the left side when the patient is looking to the left side, that's a grade 1. The next point to define is the direction of the nystagmus. Is it horizontal? Is it vertical? Is it torsional? Is it a combination of all of the above? What is the direction of the quick phase? Does the nystagmus is it fatigable, meaning it kind of dials down and then gets less intense? And what is the effect of visual fixation? Because as we know, when you use visual fixation, if it's peripheral, usually the nystagmus should go down. And, to summarize, a peripheral lesion will cause an intense nystagmus diminished with fixation, direction fixed, which is horizontal and torsional, and intensifies when the patient is looking in the direction of the quick phase. And that's Alexander's law, where basically, you have to think, as we said, that both vestibular systems are firing simultaneously. If you take the case of a right vestibular neuronitis, suddenly the brain is receiving more input from the left side. The eyes are beating to the left in all directions of gaze. The slow phase is greatest when the gaze is directed toward the healthy ear or the quick phase of the nystagmus, and gets less when you look at central gaze, and weakest when the gaze is turned toward the ipsilegional ear. That's one of the mechanisms of the central nervous system to reduce the imbalance between the two sides. So it's a compensation strategy that kicks in early on when a patient presents with a neuronitis. A quick word about the 3 laws that govern vestibular physiology. The way they were discovered by Ewald was actually prefaced by a French physician in 1842 who started selectively destroying the semicircular canals of migrating pigeons. And at the time, the thinking was that vertigo is always due to the brain. The ear is only a hearing organ, but lo and behold, when they destroyed the semicircular canals, the pigeons did not go deaf, but they started behaving erratically. When they destroyed the horizontal canal, they started running around in circles. That's the animal model of vertigo. When they destroyed the vertical canals, the pigeon could not feed themselves without a torsion of the neck. That's like the torticollis that we sometimes see in those patients, or the compensatory attitude that you see in some of those patients to align the visual plane with how they're feeling. Ewald, 50 years later, instead of destroying the canals, decided to stimulate them and came up with those 3 laws, which basically, if you understand those laws, you can decode any type of vestibular clinical exam that gets thrown at you. He noticed that a stimulation of the semicircular canal causes a movement of the eyes in the plane of the stimulated canal. And by this, he means the tonic movements, the slow phase, not the quick phase. Because the reflex, the vestibular ocular reflex, is actually related to the slow phase. The quick phase is only a compensation movement of the eye that is coded by higher brain centers above the brainstem. And those slow phase eye movement are always in the direction of the endolymph movement. The second law of Ewald is that in the horizontal semicircular canal, a flow of endolymph toward the ampulla causes a greater stimulation than a flow of endolymph away from the ampulla. Whereas in the posterior and semicircular canal, the reverse is true. A flow of endolymph toward the ampulla will cause less of a stimulation than a flow of endolymph away from the ampulla. And the one thing that we see that basically illustrates this law is BPPV, and we'll get to it in a second. So basically, once you get the history and examine the patient, after categorizing the symptoms and knowing what you're dealing with, in order to get to the appropriate diagnosis, you have to get a clinical classification of peripheral versus central, a pathophysiological classification. Are you dealing with a bilateral loss, with an acute loss, with a unilateral loss, or a paroxysmal stimulation of the vestibular system? And then you have to basically put in boxes, are we talking about a semicircular canal type of problem or an otolytic type of problem? And I listed here the type of symptoms to look for, and we don't need to go over them right now. We can read them later. So this is what a BPPV would look like when we look at the animation. Oh, should have it here. There you go. So when you lay the patient back for a Dix-Hallpike, the crystals get stuck in the posterior semicircular canal, and then when you put the patient again in the offending position, there will be a flow of endolymph away from the ampulla, which according to the third law of Ewald will cause more of a stimulation, and you will have an upbeat torsional nystagmus to show for. When the patient sits up, there will be a flow of endolymph toward the ampulla, and you will have a reversal of the nystagmus, which is much more difficult to visualize with the naked eye. Usually, unless sometimes it's very evident, but a lot of times you don't see that reversal unless you're doing a video oculography. And this table summarizes the pairing of the semicircular canals with the oculomotor muscles. For example, if we look at the posterior semicircular canal to explain why we get an upbeat torsional nystagmus, the posterior semicircular canal is paired with the ipsilateral superior oblique muscle, which by definition brings the globe of the eye downward and inward. So it's an intortor and a depressor of the globe. So when you stimulate the posterior semicircular canal, there will be a movement of the globe, a slow phase of the globe down and in, with a quick phase that is upbeat and out. This is why you have a upbeat torsional geotropic nystagmus in posterior semicircular canal when you lay the patient in Dix-Hallpike. This is what a nystagmus of a lateral canal BPPV would look like, purely horizontal, much more violent than the posterior canal BPPV. You're more likely to see those as a result of an epi that you're doing than those presenting spontaneously. Usually they have a shorter half-life. They resolve much quicker than a posterior semicircular canal. And I've seen them more frequently after I'm doing an epi, and the crystals basically convert into the horizontal canal. So clearly different type of nystagmus. This is what a superior canal BPPV nystagmus would look like, purely downbeat, contrary to the upbeat torsion that we see in posterior semicircular canal. The word of caution here, and I'll probably tackle this later in one of the cases, if you see a nystagmus like this, always get an MRI. Better safe than sorry. They are very rare. I don't see more than one of those a year. And if I do, I have to have strict criteria to decide that this is a superior canal BPPV. It has to be positional only. It has to reverse when they sit up. So I always rely on video oculography whenever I see a downbeat nystagmus in clinic to make sure I'm not missing something central. And truth be told, a lot of patients by the time they get to us have already had imaging. So I am inclined to wait when I'm convinced it's a positional BPPV. So case one is a 54-year-old female patient with a 9-day history of dizziness and right ear pain. She has a history of right ear surgery 30 years ago. She doesn't know for what, maybe cholesteatoma, but she couldn't deliver that on history. Her ear does not drain. She doesn't have an incision behind her ear. She doesn't hear much from that ear. She has temporal headaches and right facial pain. She has no facial paralysis. She denies Tullio phenomenon or Valsalva-induced dizziness when asked, and she gets dizzy when she lies down. Based on that history, could this patient have BPPV? She could have BPPV. I mean, she got dizzy when you laid her back, but in order to do a good job with BPPV and rather than overdiagnose it, the typical diagnosis requires a positive Dix-Hallpike. That being said, I've said to patients sometimes who present with a history very convincing of BPPV without any positive Dix-Hallpike that this is their most likely diagnosis. But again, based on that history, she could have BPPV. She got very dizzy when I inserted the speculum in her right ear. She had a lot of cerumen in there. I thought it was keratosis obturans at first. Suction, she got extremely dizzy, couldn't look for a nystagmus. She was nauseated. She was closing her eyes. There was no spontaneous nystagmus after she calmed down, no gaze-evoked nystagmus. It was impossible to do a head shake or a head thrust, and she was falling to the left on Romberg. That was her audiogram. So obviously she had good bone line. She only had a conductive hearing loss. And that was what her scan looked like. On the right side, she had a horizontal canal fistula. And that lady had those symptoms for a long time. She was seen probably by a couple of otolaryngologists before coming to us. And while this is not directed more to the ENT, my word of caution, always look in the ear. Her ear looked funny from the start, and her diagnosis was pretty straightforward once we got the imaging, although her symptoms were not very convincing initially. Case 2, a 40-year-old previously healthy female patient presents to the ED for severe vertigo. She describes her symptoms as spinning with nausea and vomiting, and every time she moves her head, she is dizzy. And again, that's commonly when I see this in referrals, patients are sent for BPPV because every time she moves her head, she's dizzy. And this is where I stop and say, BPPV is a positional dizziness, not a positioning dizziness and not a movement-induced dizziness. So the head has to be in a specific position for the patient to be dizzy. Her most comforting position is lying down on her left side and not moving. She denies hearing loss. She has no facial palsy. On physical exam, she has a normal otoscopy with a spontaneous nystagmus beating to the right side, more intense in right gaze, and beats to the right in every direction of gaze. So it's a grade 3 nystagmus beating to the right. Her head impulse test is positive in the horizontal plane on the left side, meaning when her head was thrust to the left, her eyes slipped from the target, which is the examiner's nose, and then came back with a corrective saccade. So her most likely diagnosis is a vestibular nerve. She had a drop of function in her left ear. And when somebody comes to you in clinic with that type of dizziness, if they haven't gone to the ED, you will have to decide whether or not you need to send them to the ED for workup for a central vestibular problem. And to do this, you rely on the head impulse test, on the spontaneous nystagmus when it's present. If the spontaneous nystagmus is beating in the same direction in all directions of gaze, that's in favor of peripheral. If the head impulse test is positive with a corrective saccade on one side, that's more in line with peripheral. And then the S stands for skew deviation. If there's a skew deviation, which is hypertropia or hypertropia of the eye, then this is in favor of a central sign. More than likely, you will not see a skew deviation. You will have a positive head impulse test and a direction fixed nystagmus. If all three are present, the likelihood that this is a stroke is close to 0. It's actually more sensitive than an MRI to predict a stroke than in the first 24 hours. So your clinical exam is much more important than an MRI. That's what most of those studies show. And this is what a positive head impulse test would look like.
And then here, then we'll see a more clear gaze above nystagmus to the left. Now look up the ceiling. There's a left beating nystagmus there. Look down to your feet. Don't know so much yet down there. left beating there, and if you look to the right to your wife there, I don't see nystagmus there. All right, we're going to demonstrate the head impulse maneuver. Keep looking at the camera the whole time.
You can see his
Okay,
corrective
and then we'll
saccade
do it to the
here.
left. And then we'll do one more time to the right. Keep looking.
Okay. So, I mean, obviously, it takes a little bit of repeating this over and over again in order to start detecting the saccade and getting comfortable in calling it out. Usually, rule of thumb, if the weakness is less than 50%, you're not going to be able to see it with the naked eye. You're going to need to do the video head impulse test. To remember the acronym that points you away from a peripheral vestibular system presentation is head impulse negative, fast phase alternating, meaning you have a nystagmus beating to the right and right gaze, beating to the left and left gaze, and a refixation on cover test, which is a skew deviation. So that lady who presented with a left vestibular neuronitis, what would be her next step? Typically, I would just give symptomatic treatment with meclizine for a few days. You can give steroids. The most recent meta-analysis on the use of steroids in vestibular neuronitis did not show an improvement in resolution of symptoms, but did show an improvement in the outcome or the amount of canal paresis on calorics down the line. Again, that doesn't transfer to the amount of symptomatic relief, but still can preserve more function if you use steroids. So whenever I am able to use steroids in a patient with neuronitis who presents early enough, which is almost never, I would give them steroids. And make sure, the first thing also to ask is, is if you saw them in the ED or if somebody saw them in the ED, make sure they don't give them a lifetime supply of meclizine or Valium. They need to be off of those to be able to compensate quickly. This is another case of vestibular neuronitis. It's actually myself a few years ago. And I'm going to walk you through what the symptoms feel like and how you recover slowly from that. So you feel, initially it felt as if I was spinning whenever I would lay on my left side, and this got better when I laid flat. It happened suddenly out of nowhere. I returned from work one day and laid down and started feeling like things are moving. And initially I thought, quite honestly, I thought I had BPPV. Every time I lay to my left side, I'm dizzy. I lay flat, I'm fine. By the next day, I had an acute right sty. And then 3 days later, the vertigo became constant. So it was like progressively getting worse until day 3 of the symptoms. Vertigo is constant even when looking straight ahead. And I had continuous left beating nystagmus in all directions of gaze. So I was looking to my right side and my nystagmus was beating to the left side. That was my video head impulse test at day 3. You can see this is the right side, this is the left side. You have head movement and eye movement. If the head and eye movement, like on the left side, are coordinated with the good VOR, they will basically be mirror images of each other. On the right side, however, you can start seeing those saccades. Some of those saccades were happening very, very fast, so they were not observable, but some of them here on the tail end were already being, you could see them visibly if you were to do the head impulse test on the bedside. My gain was down on the right side to 0.77, which is the cutoff of normal. Vertigo started subsiding around day 5, but then the patient started noting falling to the right side whenever he turned his head to the right or his ears to touch his shoulder. So basically the sensation that some of the patients might come and declare to you, I feel like I'm falling. And that sensation of falling is a purely otolytic sensation. This is related to the loss of vestibulospinal reflex afferentation. And honestly, I knew it was an otolytic problem when the patient described it as such. But when you actually experience it, you understand that sense of fall. There's no support from your truncal muscles on the side of the injury. And whenever you would turn your head, there's no communication with the extensor of the trunk to keep the head upright. And it feels like your head is dropping off. And that's exactly what a saccular or utricular dysfunction would feel like. That's exactly what a Tumarkin crisis of Meniere's disease would feel like. So as the vertigo started subsiding and static compensation started to occur, the imbalance became more pronounced, and the video head impulse test became much worse, with the drop of the VOR gain to 23% and saccades basically all over the place. On the left side, even though the VOR still was fine, there was no observable saccades, you can see the gain was dropped to 0.59. And that's what happens when the brain is trying to compensate. It basically reduces the amount of input coming from the good side to allow less asymmetry, and that reduces the vertigo. And so the balance started improving, slowly over a few weeks. There were no more spinning vertigo. The video head impulse test showed also a progressive improvement and stabilization. That's 36 days past status post onset. And finally, at month 8, the gain was back to 83% on the left, 82% on the right. There were still some saccades present, which will probably be lifelong. This is, this is kind of a scar of the problem that occurred. And so if we can go day 4, day 9, day 17, week 5, day 90, 3 months, and then at 8 months. So the recovery happens initially very fast, but then it's because you could have a patient coming at that stage with this V-hit. Not impressive in itself, the gains are fine, but still it could be a marker of an underlying vestibular dysfunction. So the vast majority of neuronitis will affect the superior vestibular nerve, which means the inferior vestibular nerve is preserved, and which means the saccule and the posterior ampulla are preserved. And about 30% of patients with neuronitis may present after a few weeks with a different complaint. That lady came a month later complaining of dizziness. Her symptoms were different at this time. She had a brief spinning sensation every time she rolled to her left side. She had a positive head thrust as a persistent marker of her weakness from a few weeks ago, but her Dix-Hallpike was positive. So she developed BPPV, which is, again, something to look for following a neuronitis. And that's something also I tell residents all the time. It's very common that a patient presents with dizziness from multiple causes. And it's also important not to categorize a patient into one diagnosis and then forget that they may develop something else. A lot of patients with Meniere's disease may develop BPPV. A lot of patients with vestibular migraine may develop symptoms related to a hypofunction, and so on and so forth. So that's why it's important to screen and do a complete exam when they come in, even though you may have the diagnosis that explains most of their symptoms. A word on the Dix-Hallpike is you don't need to do a hyperextension. Most three-dimensional studies of the temporal bone would show that just extending the head back a little bit, pointing the chin up to the ceiling is enough. You can see it here. Let's say you have a posterior canal loaded with otoliths. If you put the patient in a hyperextension position, let's say they have otoliths also loose on the other side. You can see here in that position, you are engaging the left side you are treating, but the right side may also have a movement of any otoliths that are loose. So you might have an nystagmus that is difficult to interpret because both ears are interacting against each other. Whereas if you do the modified maneuver, just pointing the chin up, you put the right side at rest and the left side is isolated and being examined on its own. And on top of that, you reduce patient discomfort. In patients who are old, you avoid any cervical spine injury, which would never happen, but that's usually their concern. And in patients who cannot extend their head at all, you just do a lateral decubitus. You turn them to the side. Typically, when this happens, I have the physical therapist in our clinic take care of that. She has a bigger table. I cannot take care of this in our usual ENT chair. So again, that's the BPPV, nystagmus of the posterior canal BPPV. It's upbeat, it's torsional. To maximize the torsional component, you have to ask the patient to look away from the center, so toward the ear that is down and on the Dix-Hall pike, and then you can maximize your torsional component. A patient who presents with BPPV, obviously you can treat her with in many ways. So I typically, if I have time, I'll do the epi myself, or I'll ask our physical therapist to proceed with the epi. If you feel like the patient is going to be extremely nauseated, just send them to the PT and make sure that they get pre-medicated before that. And that's based on the clinical practice guidelines. All of those options are equivalent. I'm going to skip the epi maneuver. There's a lot of, we can see them. There's a lot of animations available, and you can also access it on this slide. If the Dix-Hall pike shows any atypical nystagmus, make sure to evaluate for multiple canal BPPV, for unusual type of BPPV, whether it's a cupulolithiasis or a horizontal canal lithiasis, or a central cause. And one thing to remember, a positional nystagmus, patients who, when you lay them back, they're not dizzy, they have this very mild, let's say left-beating nystagmus on head left that has no latency, immediately starts, and doesn't remit with visual fixation. This is a central positional nystagmus, and the #1 cause of central positional nystagmus, whether in a vestibular clinic or elsewhere, would be a migraine pathology. Okay. So moving on to another case, a 60-year-old woman with non-specific dizziness and gait instability 3 weeks after discharge from a hospital following a 1-week stay for pneumonia. She was treated with cephalosporin. There were no aminoglycosides used, and a tentative review of the chart does not show any vestibulotoxic drugs. She has a COPD, and she has a remote history of vertigo. About 20 years before she presented to you, she had a vertigo that lasted 1 week. She was diagnosed with Meniere's disease. She doesn't remember having any hearing loss, any tinnitus. She doesn't currently endorse any hearing loss or tinnitus. On physical exam, she has a low amplitude right beating nystagmus only when she looks to the right. So it's a grade 1 nystagmus. She's incapable of tandem walk or standing on foam, and she has a positive head thrust to the left. So based on this information, what we can tell from this is that she has a left hypofunction. Her head thrust is positive to the left. She has a right beating nystagmus on when she looks to the right. You get lab testing, and you can see here on the rotary chair, the rotary chair has 2 protocols. One protocol where there's a sinusoidal oscillation of the chair, and you're tracking where the eyes are going. You're tracking the speed of the eye movements in relation to the speed of the chair. So the gain, which is the leftmost graph, is the speed of the eye movement divided by the speed of the chair, which gives you the gain, which should be along that range. She had a normal gain. But then you look at the right-hand picture here, the phase. The patient had a phase lead. Basically, the eyes were not landing where they should after multiple oscillations. And that tells you that there is a problem with the vestibular system. There is a vestibular system dysfunction. It doesn't tell you which side. It's your clinical exam that's telling you the left side is weak. So she obviously has a left vestibular hypofunction that is uncompensated. The second protocol of the rotary chair, which is usually less often positive, so less often useful, except in the very acute stages. I've seen it more useful in the acute stages. You have the gain. It's called the step velocity protocol. You basically accelerate the chair up to a point and then suddenly stop, and then do the same thing going to the opposite side. And you check for the nystagmus that this creates upon the interruption of the movement. And if the gain is low, like in her case, when she accelerated, her gain was very low. Her eyes are not picking up on high-speed movements. And she had a nystagmus that was very short-lived, which means her VOR is not doing well. And that also paints the picture of the hypofunction. That specific patient also had absent calorics on one side. Her C-vamp was also absent on the left, signifying that the inferior vestibular nerve was affected. So the most likely diagnosis is a decompensated vestibulopathy. She probably did not have Meniere's disease 20 years ago. She had a neuronitis attack, episode 20 years ago. She recovered from it, but then she got older, she got sicker, was hospitalized for 3 weeks with pneumonia. She was not moving a lot. That could be enough to decompensate in certain cases, especially if the compensation was not very strong to start with. The pathophysiology of decompensation, which would be a big component of what you would see in clinic when you see a dizzy patient. A lot of them come with a decompensated vestibular problem. Cervical disease can cause that. Trigeminal stimulation, whether it's atypical facial pain, patients with chronic sinusitis and a lot of trigeminal symptoms can develop that. Migraines, medications that are CNS depressants or other, a stroke or any type of central process can cause that. And I recommend that everybody reads this article from the New England Journal of Medicine. It's a book chapter, actually, from a physician who developed bilateral vestibular hypofunction following treatment for tuberculosis with IM streptomycin back in the 50s. And he describes very vividly how he lost, the symptoms associated with the loss of vestibular function and how distressing they can be, and then how he recovered with rehab, but doing the rehab on his own, basically. And I find this article a very interesting article to understand the compensation mechanisms that come with this. Again, this is what oscillopsia looks like. This is how miserable patients with decompensated vestibulopathy can be, even if they don't have a full loss of function on both sides. This is a 50-year-old patient I saw last year, maybe. She presented with an idiopathic bilateral vestibular hypofunction. Her V-hit is terrible. I mean, she has gains of almost zero. There's no, there's basically no communication with her vestibular system and her oculomotor nuclei. That lady had no autoimmune pathology, no surgery, no Meniere's disease, no vestibulotoxic medication. She probably has a genetic component to it. There are some studies talking about genetic bilateral vestibular hypofunction, nothing that we can test for in clinical setting, but she's as miserable as her V-hit implies. This other lady presented with less of a dramatic drop in her function. She's a patient with otosclerosis who had a right side cochlear implant a couple of years before coming to see me, and then presented with progressively worsening balance and oscillopsia. Her V-hit showed this. She had low gain on both sides. It's unclear if she had the low gain before the implant surgery. And at that point, it's a moot point. I mean, she likes her implant, but who knows what her balance function was before. Her CAT scan is impressive. She has, one of the worst cochlear capsule otosclerosis I've seen. And that patient was put through an aggressive course of physical therapy, and she did good. She went skiing after a year thanks to our vestibular therapy team. But then she would periodically call and say, I need to go back to PT. I think I'm slipping again. And I think we'll have time for one more long case of basically Meniere's disease and vestibular migraine. And we'll go over the latest guidelines of the American Academy about Meniere's disease. So this is a 47-year-old patient, first evaluated in June 2016. She has a long-standing history of vertigo lasting days, bilateral tinnitus and hearing loss, but no oral fullness. She notes worse hearing loss on the left during the attacks. She also notes severe headaches with or following the episodes. She misses up to a month of work a year because of her spells. She works as a nurse. She had a gentamicin injection, or so she says, in her ear 20 years ago, and unclear which ear. She has severe history of migraines, up to 20 episodes per month with visual auras, photophobia, nausea, vomiting, and vertigo occasionally. She has failed propranolol, verapamil, amitriptyline, and a recent trial on venlafaxine. That was her audiogram on the initial visit. She did have this mild hearing loss and the low frequency bilaterally. But she, how would you label this patient? Is she a vestibular migraine, a Meniere's disease, both? For each, is it a probable or is it a definite diagnosis? So we can review the criteria for Meniere's disease that's set forth by the 2020 criteria. Is you have to have 2 or more spontaneous attacks of vertigo, each lasting between 20 minutes to 12 hours. Audiogram showing low to mid-frequency hearing loss in the affected ear on at least one occasion before, during, or after one of the episodes of vertigo, and fluctuating oral symptoms in the affected ear. The probable Meniere's is more than 2 episodes of vertigo or dizziness lasting 20 minutes to 24 hours. So obviously, if we follow the 2020 AAO criteria, you can say from the start that she has the diagnosis of Meniere's disease. Back in 2016, if you look at the criteria of the Berenice Society, the thresholds had to be at least 30 dB worse in the affected ear than the good ear, which was not her case. She had a pretty equivalent audiogram. Of course, the diagnosis was at the time definite vestibular migraine, probable Meniere's disease of the left ear, because the audiogram was not vividly positive. The diagnosis of vestibular migraine, patient has to have at least 5 episodes of vestibular symptoms of moderate or severe intensity, lasting 5 minutes to 72 hours, with a current or previous history of migraine, and 1 or more migraine features with at least 50% of her episodes, headaches that have a migraine quality, photophobia and phonophobia, and visual aura. And that's, I think, one of the hardest things to make patient understand is that a migraine can be a migraine without a headache. And second is that a migraine headache does not necessarily need to be a headache that you need to sleep off. It has to be at least a moderate headache, but it has to have 2 of those 4 qualities: one-sided location, pulsating quality, moderate or severe intensity, and aggravated by physical activity. So it's important to think broadly about the phenotype of migraine when you're identifying those patients. So obviously the first statement of the Academy was to rely on their latest definition about definite or probable Meniere's disease with 2 or more episodes of vertigo lasting between 20 minutes up to 24 hours, with fluctuating or non-fluctuating sensorineural hearing loss, tinnitus, or pressure in the affected ear, when there's not a better diagnosis. Always assess for a vestibular migraine coming in a patient coming with Meniere's disease. The comorbidity is staggeringly high. Some studies cite that up to 56% of patients with Meniere's disease have a lifetime prevalence of migraine, whereas the general population, it's around 13%. The audiometric testing should be obtained when assessing a patient for the diagnosis of Meniere's disease. That's the single most important diagnostic test we have for this. Unfortunately, so far, there's no other gold standard. So at initial diagnosis, she fulfilled criteria for definite migraine, probably left. Great. And given that she had failed multiple migraine preventative, I counseled the patient, let's treat your headaches first and then reassess what's underneath. And we proceeded with Botox according to the preempt protocol, treated her migraines. Her neurologist increased her amitriptyline and effexor doses, and she followed lifestyle modifications with low salt diet and migraine triggers. And she was referred to a nutritionist for more counseling. So the treatment of, you should treat, the question is, should we treat vestibular migraine and Meniere's disease simultaneously? And I do tell patients we have to treat both problems, but I do them in a sequential manner in order to know what's working, basically. It's very important to educate the patient about the pathology and about the natural history, which sometimes can have spontaneous remission. But if you tell the patient who's 45 years old in the midst of their, in the height of their career, that you might want to wait 10 years for it to go on its own, I mean, that's not also acceptable. I mean, they need to be productive and working. And some people may have their quality of life completely wrecked with one episode a week, and others, it takes them to have 5 or 6 episodes a week to be wrecked. This is a completely different perception. Also, it depends on their job. A lot of patients are anxious about losing their jobs, about having to go on FMLA, about losing income, and for some, losing one day of work is distressing enough, and for others, they have more flexibility. So it's always important to take into account patient factors as you're deciding the plan of treatment. The symptomatic management of vertigo is essential, and we should not forget about that. I don't like meclizine much because they can get it over the counter, so I try to steer them away from something they can get their hands on and use it as a crutch. I'd rather give them Phenergan as a first line, and then Valium if they don't respond to Phenergan. And then looking at symptom reduction and prevention and prophylaxis, the first step is always dietary and lifestyle modifications. The rule of thumb is try to get the patient to a salt intake of 1,500 milligrams or around. It's very difficult. So I usually tell patients, try to reduce as much as you can. Try to aim between 1,500 and 2,000 milligrams per day of sodium. So she implemented her low salt diet, amitriptyline and effects were increased, Botox injection ×2. So for 6 months, headaches and dizziness were controlled. 5 months after initial visit, she has a severe vertigo attack with left oral fullness, roaring tinnitus on both sides, decrease in left hearing. She fell and hit her head. Severe symptoms improved with oral steroids. She presented 3 days later with persistent non-spinning dizziness and a stable audiogram. Her video head impulse test showed a borderline low gain on the right, which is the good ear. So we proceeded at this point with the headaches have been in control, and she still got severe episodes. So we did a steroid injection on the left side, started her on vestibular therapy. She had another bad vertigo attack, and her attack were always followed by a fall, and she would injure herself. Her MRI was repeated. It was unremarkable. Vestibular testing was done in the interictal period, was normal. And that listed the treatment options we have for Meniere. The Academy weighed in on almost all of those points that I showed on the previous slide. First of all, I personally don't get an MRI if the patient has a traditional type, like typical presentation of Meniere, unless they don't respond to any treatment plan. But if they have anything super added or anything that doesn't, fit the classical presentation, I don't hesitate to get an MRI. I don't get the, ECOG I don't get, and I don't get a VNG unless I'm starting to think about more aggressive measures, which in her case was starting to build up. In my mind, I wanted to have a baseline of her vestibular function. That's why I started with a V hit. But then when she fell and hit her head twice, I started thinking of drop attacks potentially that were occurring in her case. I started thinking of maybe the concussion that she suffered from could have affected the vestibular function, and that's why she was persistently dizzy following her attacks. And we wanted to get a baseline, basically. The Academy leaves it as an option whether or not you want to put patients on diuretics or beta-histine. I certainly gravitate away from diuretics most of the time because most patients are already on them or have tried them. I do like beta-histine when the patients can afford it. You get it from a compounding pharmacy. And it increases blood flow into the cochlea. That's the one thing that we know about its theoretical effect. So if anything, it helps recovery from any attack of Meniere's rather than preventing the attack of Meniere's. But I have had patients who did well on it and others who didn't respond. So it's a low risk strategy to use. Of those of you who've heard of the Meniere device, the positive pressure therapy is recommended against. It doesn't work. It's very expensive. So we're going to skip that. The IT steroid treatment is considered as an option by the Academy. And also some patients with Meniere's will respond and others won't. And in her case, we started with the IT steroid injection to the left ear, for which she didn't respond. So we proceeded with a sac decompression. She had significant relief over several months, with one episode clearly related to a migraine headache 3 months after the surgery. We continued managing her headaches with Botox every 3 months. Her hearing test post-op was similar to there was no loss of hearing. And then 9 months of relief of symptoms, she got assaulted at work, basically, and got hit to the head again. And episodes return, lateralizing to the left ear, constant left tinnitus, drop of hearing on the left side. And she started having drop attacks. We did gentamicin injections, recovered somewhat with rehab, and then proceeded with, eventually, in her case, with a labyrinthectomy. I think I'm running short on time, but I'll wrap this up. So IT gentamicin should be offered to patients with active Meniere's disease not responsive to non-ablative therapy. And the risk of hearing loss is really minimal. So when you get a patient who's really miserable, you follow them for a long time, you made sure that the other side is staying put. You may, with enough counseling, tell them, gentamicin might be the next step. So she did not respond to gentamicin injections. We finally decided on a labyrinthectomy. We talked about the small chance of bilateral Meniere's disease. We talked about her very good residual hearing. We did a labyrinthectomy 18 months after the initial visit. So that's how long. I would never go to something aggressive very early. So it's after 18 months of conservative management that we elected for an aggressive management. She got vestibular rehab post-op. She returned to work within 2 weeks. She had no hearing on her left side. And labyrinthectomy was offered, should be offered to patients who have failed less definitive therapy and have non-usable hearing. And in her case, we had done the gentamicin before then. So is there a role for vestibular rehab in the treatment management of vestibular migraine or Meniere's? There is a role for chronic imbalance, so assess the patient between episodes, check if they have hypofunction type symptoms, and then send them to PT. In this case also, I feel like, although it's been written about with the concept of prehab, basically if you prepare the patient with rehab before doing an ablative procedure, whether it's a labyrinthectomy or a vestibular schwannoma resection, some patients may do better and quickly recover faster from their imbalance. Obviously, avoid vestibular therapy in the acute setting of vertigo. And if a patient starts feeling motion sick during therapy, make sure that you're sending them to a therapist who knows how to dose the severity of the exercises. So post-labyrinthectomy, that patient continued to have Botox, no headaches, vertigo-free for 9 months again. Seems like it's her magic number. Then the episodes returned, but this time on the right. We had counseled her extensively about the risk of a right-sided Meniere's, and then she finally developed it. She had a drop attack, and her hearing started going down on the right side. She was not responsive to oral steroids or IT steroids, was having clear-cut vertigo episodes without migraine symptoms and drop attacks. We avoided gentamicin in her case, but knowing where her hearing was going on the right side, we decided to proceed with the left CI to get her some hearing from the ear that was had the labyrinthectomy, in preparation for the right side dropping completely. And that's one of the statements of the Academy. Counseling for amplification and hearing assistive technology is important. And again, it's the handful of patients of Meniere's who are going to have significantly profound hearing loss, and this is usually the ones who you've caused the hearing loss. And rarely Meniere's will present itself with such a severe hearing loss from the get-go, but it's been reported, obviously, and you will see it in your clinic. So we finally did the CI on the left, and then her hearing on the right kept going down and became profound. And her disease burned out at some point on the right side. She stopped having severe vertigo attack. She had some oscillopsia, but she kept going with vestibular therapy, and she was able to stay functional and work. And we proceeded with the right CI last year. And very unusually, her post-op audiogram following her right CI showed a recovery of hearing We don't know where that came from. And we're actually presenting it at the Super Saturday as a case to the ANS. So patient outcomes is the last statement of the Academy about Meniere's disease. It's very important to document resolution, improvement, or worsening of each of the components of the symptoms, vertigo, tinnitus, and hearing loss, and any change in quality of life in patients with Meniere's disease after treatment. We do lack a lot of standardized outcome measures, especially for this disorder that spans multiple symptoms. And it's very important to keep good documentation to decide the next step. I'm going to stop here. There's a lot of other cases that I would have liked to share with you, maybe with a different session. But I'm going to stop here and give the mic back to Mallory.
Thank you so much, Dr. Rizk. That was awesome. I'll open it up for questions from anyone. We're kind of at the limit, but feel free. Okay, well, I think if no one has questions, Dr. Rizk, I'll just stop it there since we're right at 6. Thanks again. That was a great talk.
Okay, bye-bye.
Bye, everyone.